on the chat thing there. With regard to Rebecca's question, as far as lamotrigine, you always have to be aware of that there could be some combination of CNS depression or enhanced CNS actions on those. And let me just see real quick, and if there's a specific drug interaction there. The biggest thing is probably the combination, more of a pharmacodynamic issue from that. If you look at drug interactions, pretty much drugs.com will list it as elderly may be more impaired, have more impaired thinking than anything else. So that's going to be one of the issues that are there, but it's primarily the an increase in side effects, which I think is more of a pharmacodynamic issue there. There's actually a paper that was done in '98. I was seeing here that that showed there's actually one in '98 and 2012 where people looked at it and showed some of the actions that were increased pharmacodynamics there. So. Okay, so one of the things is, let's pick up from what I want to get covered this afternoon as we finish the discussion of drugs. We are going to talk a little bit about the guidelines for bipolar, and there's several that are out there, and I'm just going to mention those to you. We'll hit some highlights of them, and that's about it. So let's some of what we're going to cover a little bit beginning this afternoon should be somewhat of a renew and should build upon what you guys had last week. We have been talking about bipolar disorder and some of the categories which fall into, get a full screen here, some of the categories which fall in with regard to the investigational therapies. In other words, they haven't been proven, but people have had some success, is that looking at that since mania may be due to elevated norepinephrine, then the rationale was drugs that may reduce norepinephrine availability have been suggested, and two in particular have been clonidine and propranolol. Clonidine is an alpha-2 agonist, and when you stimulate the alpha-2 receptors, that decreases norepinephrine release, or not release. It actually decreases norepinephrine release, but it also can affect some uptake in some cases. And propranolol, most people think of propranolol as being a beta blocker, but actually some of the work I did and some other people did at Charleston years and years ago showed that propranolol can deplete norepinephrine by actually getting into the neuron and displacing it. Another thing has been that people have tried to say, okay, by stimulating GABA systems, so things that may have a GABA mimetic action, these would be good. So clonazepam has been suggested, but it takes pretty high dosages, and some people question as to whether this is truly a good effect with regard to using a benzodiazepam, number one, in patients that may have a propensity for substance abuse, and number two is the effects. This question is really just is it more the sedating effects of clonazepam? So one of the things may be is what people are saying is anti-manic, may simply be more of a sedation thing. And then one of the things we have seen verapamil specifically, but there have been some suggestions that other calcium antagonists may have a benefit there, is sort of as a last resort or a fourth line agent at least. Verapamil has been used. That's assuming you've already tried like lithium, carbamazepine, valproic acid, and others. The whole basis of the verapamil is that there is the bipolar may involve calcium. They refer to this as the calcium hypothesis. So basically, the idea is that it might have those actions. Verapamil in particular also has what we call a dromotropic effect, which it tends to decrease nerve firing. And so that's a big issue that may be coming into play here. So we've talked about these anticonvulsants, which have been mood stabilizers, but again, one of the things we saw is when the atypical antipsychotics came out, basically we started seeing more and more of a situation where that these were being moved over to be used for the treatment of bipolar. So when you look at it, this is just sort of another depiction of the graph that I showed you guys yesterday. There, the thing about it is that we've seen a movement of atypicals being used quite a bit. So a lot of the things that we covered last weekend is going to apply, and so we're not going to need to go over a lot of that. We'll reinforce some things that we talked about earlier. But you know, with antipsychotic therapies, I told you there used to be a lot of first generation typical agents or conventional agents. There was like 14 of them. And then we actually have a few more than just the 6, but we have several of the atypicals that moved in, and probably quetiapine, which was Abilify, was the one that made the quickest jump to start advertising heavily into the with regard to the treatment of bipolar. As I said yesterday, my personal opinion is that basically that Abilify gained a big jump and probably helped in the misdiagnosis when they started doing their ad campaign for using their drug, because we did see several patients that, as we said yesterday, that there was several agents where, or several instances where people were being treated because they showed up for the depression. So we started seeing that ad campaign from Abilify, and people started thinking that, you know, hey, maybe this patient's not responding well, or maybe this patient's developing more mania, and it might be that there is the situation where that we're dealing with a bipolar patient. So in my opinion, it was one of those situations where that the ad campaign, both what was shown to the direct-to-consumer advertising, but also mainly with the physicians, is getting them to maybe consider that their patients may be bipolar rather than just simply depressed. So what we've saw, again, without going through the mechanism, what we've seen with regard to the atypical antipsychotics is basically this. There's pretty good evidence and clinical trials and case studies and so forth that these atypical antipsychotics were efficacious when treating acute mania. Probably what we had, so we had efficacy for acute mania. Probably what we see that highest evidence for was probably olanzapine, but also we saw some nice stuff with these other agents too. The onset of action typically was observed in 2 to 4 days, which is pretty good. And probably the strongest evidence we had was that maintenance efficacy we saw both for managing mania and depression, olanzapine. Now, here's the thing. Do we have it for all the other agents? Not directly. But the other agents have set back a little bit. And there's an issue of, if I'm a drug company and I am going to, and I've got an antipsychotic, an atypical antipsychotic, olanzapine has sort of paved the way and suggested there's pretty good evidence for that. So if I'm another drug company that has one of the other antipsychotics, then one of the big issues that I might want to consider is whether I want to do clinical trials. If I had, you know, some unique aspect and I think I could get exclusivity or things like that, then I might move that way. But a lot of the other drugs have just sort of lived off, if you will, the olanzapine. I mean, quetiapine, Abilify was one of the ones that sort of stepped out of there. But we really gained a lot of information with olanzapine, and since most of these drugs, if not all of them, are now generic companies are not going to run that. So if you look at the evidence for olanzapine, what you saw is, and I'm not going to ask you about, these specific studies, I'm just sort of giving it to you. So there was a double-blind random trial, inpatient, ran for 8 weeks, carried it for 6 weeks, 6 months, open extension that we need if they wanted to. And so what they had is they had olanzapine by itself, they had olanzapine plus fluoxetine, and then they had placebo. This was probably some of the studies that worked into the Symbyax evaluation. So when they did this, pretty much they showed that so Towen in 2002 demonstrated it was effective, and it was effective as monotherapy. It was effective in combination with fluoxetine. Paroxetine also actually has done some studies. Some people consider it probably more studied because it has 3 double-blind studies. All of these were add-on type studies, and all of them, all of the different agents combinations were double-blind against placebo. So you have a placebo-controlled, but they also looked at a comparison with imipramine, Effexor, and then combined lithium and divalproex. So that showed us some issues. So what we found was that lithium alone was as good as lithium combined with an antidepressant, and that didn't matter which antidepressant. They used paroxetine, they used imipramine. But what they showed at low lithium levels, which was less than 0.8 serum concentration, the antidepressants actually look better. So at low lithium concentrations, basically the antidepressants were actually better than the lithium alone. If you combine the mood stabilizers, they were equal to combining a mood stabilizer and paroxetine, but their big issue was the mood stabilizer combination. So using like carbamazepine and lithium or something like that had more side effects. So what the argument was that, hey, look, they're equally effective, but when we combine this with paroxetine, we had fewer side effects. So that was their big push on that. And then didn't matter if it was paroxetine or Effexor, both were equally effective. And people on paroxetine, they made an argument that there was very little switch rate or had very low switch rates. They didn't have to switch to a different agent. One of the big things is when we have to switch drugs because of side effects or loss of efficacy, that creates a problem. It creates a problem because it means the drug has has stopped working. You may run into compliance problems. You have to sort of change the drug. So when we have drugs that we have low switch rates, those are preferred. So when you look at people that are on mood stabilizers, and then we looked at whether we had to switch the antidepressants, what we typically saw was when the antidepressant was a tricyclic antidepressant, a monoamine oxidase inhibitor, these really shouldn't surprise you because of the side effects, or even Effexor. So we see that there was a higher switch rate on those ones. Whereas if they were on SSRIs or bupropion, we saw a lower switch rate. So the SSRI, basically the take-home message is a lot of the SSRIs were actually better, and you're not having to switch the drugs. If they weren't on a mood stabilizer, regardless of the antidepressant, we did see a higher switch rate. So let's take a look at some of the therapies. So if we're starting off with bipolar disorder, the drugs that seem to have effect as monotherapy is we've seen lithium or valproic acid works pretty well. The atypical antipsychotics work pretty well. And then after that, we've seen carbamazepine or lamotripine And then, even though the gabapentin and topiramate, for monotherapy, typically those are not going to be effective. There may be a few patients they work on, but in general, the topiramate, remember, probably its efficacy is really questionable, but it will prevent the weight gain. It may add to do the weight gain. But preferred was going to be typically for monotherapeutic is preferred is usually lithium or valproic acid or an atypical antipsychotic. That's for a single agent. When we start looking at combination therapy, typically it's going to be a mood stabilizer and an atypical. So a lot of times lithium or valproic acid, add an atypical on it, works pretty well. This one can work, but the question is, as I've said several times, is the benzodiazepine. One of the questions is going to be, is there a potential substance abuse problem? And the other issue is that if you're using a high dose of the benzodiazepines, one of the big things that you got to worry about is are you seeing just sedation? Lithium or valproic acid plus a neuroleptic. Typically, the neuroleptics, when we use that term, are going to be the conventional agents. What I would tell you is this drug here, the neuroleptic, is probably, although it may work, you're going to have a higher problem with side effects. The benzodiazepines, although it may work, going to have a concern with either substance abuse or oversedation. So really, as far as the lowest incidence of side effects and everything, is probably this first choice probably looks pretty good. We've also seen combining 2 or more of the mood stabilizers, carbamazepine, lithium, so some of those. And we can also see using a mood stabilizer or an atypical antipsychotic and antidepressant. So we can use either a mood stabilizer, an atypical, and then an antidepressant. In fact, Symbyax was basically the idea of using an atypical plus an antidepressant. Now, there are numerous guidelines that are out there with regard to treatment of bipolar. The big thing is, this is sort of like when we were treating schizophrenia. First of all, we have to individualize the treatment. We should do this for any drug. Rebecca, the neuroleptic is typically antipsychotics, but most frequently when they talk about the neuroleptics, they're more frequently referring to the conventional agents. So the neuroleptic is, although I have seen some people refer to neuroleptics as just in general antipsychotics, but for the most part, neuroleptics, we see people usually when they refer to a neuroleptic, it's usually a conventional agent. You have to look at, how they're referring to it. So you have to get other information if they're trying to include it. But I have seen many times that more classically, the neuroleptics are the conventional agents, but I have seen in some papers and things like that where they use the term neuroleptic to include all antipsychotics. Okay, so when we're dealing with bipolar disorder, we need to really focus on, what symptoms are we addressing? How are they responding to the treatment, and side effects? I mean, this is not unusual for any of the drugs, any drug we use. We always want to see, what symptom of the disease they're expressing, especially the ones that seem to have brought them in for treatment. Those are the ones that we try to address, and they may not necessarily be the most important of all the symptoms they have, but it's going to be the most important to that patient. That's what's brought them to treatment. We're going to need to see how they respond. And not only are we going to see how they respond, we need to make sure, because as I've said before, some of these agents, we've got good efficacy, but we also have a lot of side effects. And the side effects may express differently in different patients, and different side effects may have different impact on different patients. So a big thing is, just like with schizophrenia, bipolar disorder is a very dynamic process, and you're going to have to use multiple treatments and strategies. A lot of this is going to deal with comorbidities that you have with these patients, how to deal with the comorbidities, how your treatment will affect the comorbidities, how the comorbidities might affect your treatment. And so when you look at all of that, and again, I think I made this statement the other day when we talked about schizophrenia drugs, The thing about it is that people love to have algorithms. They like algorithms, and people like to establish these algorithms because it's sort of like a menu, which means when my patient comes in, I can go, oh, this symptom or this particular thing, then I'm going to give you this drug. The problem is, again, very similar to schizophrenia, we don't have a decision tree that can actually predict optimal therapy. In fact, our decision trees for schizophrenia and bipolar are pretty generic in many ways. And I'll point this out to you as we go through these next few slides. So when we look at there we go. So there have been a number of guidelines that have been put forth. American Psychiatric Association published in 1994 treatment for bipolar. And those guidelines had the basic information of, or the basic statement was the guidelines were to provide basic information on diagnosis, clinical course, epidemiology, and treatment. So basically, how do you diagnose it? What do we expect to see as the disease goes through its course? The epidemiology of it, what's its incidence, prevalence, what groups was there, and suggestions for treatment, okay? Key point here, and most of these guidelines will say this. Many of these guidelines, somewhere in their text, will say something like this: not considered standard of care due to the variability of the disorder and the need to individualize treatment. What that's saying is basically these are suggestions. I sort of think about this when, if you guys remember Pirates of the Caribbean, when they were acting, the captain said it was the Pirates Code. The issue is, and the person said, well, it's a code. And he goes, it's not really a code. It's more or less like guidelines. So Dr. Gupta, the thing about it is that people have said that algorithms perform better than psychiatrists. What you have to be aware of is that the point becomes that there is so much variability. And when you're collecting this data, really the issue becomes how they've identified that. The point becomes is that there are many times that you will find that these guidelines would be what a person would do even without those. And you will find that there is a sort of a unique thing, or not a unique thing, a sort of general component there. But the point becomes with guidelines, reason I'm saying about guidelines is you may get a bunch of patients that following the guideline nails it right on. But there's going to be a lot of patients that may not meet those guidelines and following the guidelines. So it's a big issue with regard to it. So these statements that the algorithms, sometimes you have prescribers that don't really know the drugs. So they're just prescribing by the seat of their pants. So the guidelines do provide some suggestions, but ultimately which drug you're going to choose is going to come down to you making the benefit risk for that particular patient. So what we find is that regardless whether you follow the guidelines, whether you don't follow a guideline, many people will have guidelines and say, we sort of follow those, or these are the ones we like. What you need to do, again, key point, this is a dynamic disease. A lot of changes, a lot of variability in patients and things like that. So one of the big things you're going to deal with is you've got to realize that you're going to have to monitor these patients pretty frequently. Janelle, one of the things I'll make a point is some people like to go to psychiatry. One of the issues becomes is that a lot of people feel like there's a necessity. There is definitely a market for if you want to make a lot of money and have, I could get in, people come down on me for this. When you talk to medical schools, you know where all their people want to go? In the beginning, a lot of the people say, I want to be a general practitioner. I want to go back home and practice medicine. But one of the things you see is the most popular, what people like to go to is dermatology. You don't have people on dermatology is you have a big business, and basically, you know, you can have regular hours. There's a lot of dollars there. It's like several years ago, they were saying general practitioners could make between 120 to 160,000. Dermatologists were starting off in 300. So the other issues, cosmetic surgery has been a very popular thing, and I see a lot of people going into cosmetic surgery and minimizing procedures. A botched cosmetic surgery can be, you know, pretty expensive from a liability. But a dermatologist, most of them are not on call. Even if you have somebody coming in with a severe reaction, those, you know, the ones that work at a hospital may be a little bit more. And so, you know, it just varies. But, you know, one of the things is some general practitioners are having a hard time keeping their doors open because they have to see so many patients in order to, you know, get everything covered. So, but when you're managing these patients, one of the things is you need to monitor the patient clinically and lab, you know, so you need to have eyes on the patient, kind of communication with the patient, find out what's going on, find out if the drug's working, find out if there is any side effects that may be emerging. Same time, you're going to be doing a lot of monitoring on them, lab monitoring, depending on the particular drug. Suggested that the regular office visit should be at least 1 to 3 months. I think really with a bipolar patient, you know, 3 months may be really questioning it unless they're really, really stable. Even early on, 1 month may be not enough. You maybe need to see them per week. Patients have to be educated about, just like we talked after you guys saw the video, patients are going to get a lot of different information from the internet, from their peers, magazines, all sorts from the media. So it's important that you stay ahead of that. So one of the things is, I always tell my students, is to every now and then check on the internet what seems to pop up. You know, for example, if you're dealing with bipolar patients, just Google bipolar on the internet to see if, you know, what's coming up. Look at magazines as you go through the checkout line, you know, things like Cosmo. If you hear anything on the news or media about bipolar, these are things that your patients are hearing and could impact your therapy. They need to know what to look for, not only for, you know, as far as the disease state, but also for side effects. And you need to let them know that many times, if they will let us know, we can address and either prevent or we can potentially modify those side effects. What you don't want is somebody to quit taking their medicine because they think it's either not working, or they feel like it messes them up more than the disease, or they think they're cured. Identify with them their target symptoms, and you know, talk to them about if these symptoms, what are some symptoms or target symptoms that they should be looking for from the mania, from the depression. When these start to emerge, it's very important that they let us know or contact their prescriber so that we can change it, change the drug or alter. So we may have to switch them off a drug, or we may need to, you know, add another drug or something, but we need to stay on top of their therapy. So what we really are trying to do is pretty standard for most mental disorders. We want to optimize their social and occupational functioning. We want them to have as good a life as possible, okay? Knowing that we're giving them drugs, we know there's always a possibility of those, and we need to let the patient know, and many times we can either minimize those adverse events, or we may even be able to completely stop them. What we want to be careful about is polypharmacy. We don't want to just keep giving drugs on top of another drug, nor do we want our patients doing polypharmacy by borrowing drugs from their neighbors, abusing drugs, developing substance abuse issues, altering the dose of the drugs, those type of things. We want to be careful about making sure we get a good medication history on these patients. And one thing to keep in mind is some of these symptoms that may emerge, that patient may go to another doctor
and get some benzodiazepines, or maybe getting Ambien or one of these sleep medications, you need to know about that. Sometimes these patients may not want to tell you that because they have seen another doctor and got a prescription. Also, sometimes they may be trying some of these health type things that come up. There's all sorts of things over the internet. People can buy. One of the big concerns we're going to be interested to see is CBD. We know that there's been CBD that has had some contaminants in it. Big thing that's been going through is the vaping, is people vaping and having toxicity. We focused on the lung damage, but also some of the stuff they may be vaping may be producing some symptoms that could potentially be like produce mania. My voice is for some reason seems to be dying. So the APA basically published some guidelines for bipolar. They released these in 2002. They updated them in 2004. The changes that you saw was basically pharmacotherapy. In the update, they recognized some of the emerging treatments. They addressed some of the potential treatments for mixed episodes. They refocused on the approach to depression because earlier on, most of the drugs did pretty good on mania, but did very poorly or a variable job on depression. They also suggested some approaches for maintenance therapy that were new compared to the other ones. And they actually had a whole selection on children and adolescents with these guidelines. Now, interestingly, these practice guidelines, and again, there is, I think, a disclaimer with these APAs, basically that says these can't be considered standard of care, okay, because patients differ so much. So what their practice guidelines suggested was start with lithium or divalproex and a second generation antipsychotic. Okay, that's sort of, you're going to see this as sort of a ongoing or central approach, if you will. If the patient is less ill, for example, that's going to be your decision. But if you think the patient's symptoms, you could start with monotherapy, either with lithium or divalproex or one of the atypical antipsychotics. That ultimately is your decision. If you have mixed episodes, we know that lithium is not as good. So either divalproex or antipsychotic works better for the mixed episodes. And a general statement is that if you're going to use an antipsychotic, then the atypicals are going to be preferred over the typicals. So that's going to be a standard theme through a lot of these guidelines. If lithium or divalproex are not, for some reason, a viable option, then the suggestion is to use carbamazepine or oxcarbazepine. So that's sort of their approach there. When you have breakthrough episodes, so for example, you've got them on maintenance therapy, and then they have emergence of either mania or depression. One of the things is to check to make sure that the maintenance medication dose has been optimized, and that includes, are they taking it, looking at the dose that you prescribed, you may need to up it a little bit. But assuming that's occurred, consider using an antipsychotic, and the antipsychotic is typically going to be an atypical antipsychotic. If that doesn't work, consider adding lithium, divalproex, carbamazepine, oxcarbazepine, and then if the patients continue to be refractory, it's clozapine or ECT. So also their guidelines is that this is where they focused on the depression. So if the patient is already in treatment, is already on a mood stabilizer, so if they are, then optimize the dose, which basically means probably increase the dose of the mood stabilizer and then add an antidepressant, probably an SSRI. If that person is not already in treatment with the mood stabilizer,
then what they do is maybe use lithium or lamotrigine for more severely ill patients, lithium or an antidepressant, and with psychosis or at a high suicide risk, antipsychotic or ECT. So when you look at these guidelines, basically what we're seeing in general, and again, there's several different guidelines across the world that people have used. General, what we've seen for treatment of acute mania is typically combination therapy. Okay, combination therapy works, and it tends to be more common. It's more the rule rather than the exception. We see that lithium and divalproex really, many people refer to them sometimes as the cornerstone to treatment, because we start off with those. And then we do see more use of these atypical antipsychotics for acute treatment and for maintenance. We didn't see this as often because when we were seeing in the past, because we saw conventional antipsychotics, many times the biggest issue that we ran into with them was we ran into so much side effects associated with those. We've talked about a big issue with regard to misdiagnosis. There was actually a study that there was actually multiple studies that occurred, and what they saw that the rate of misdiagnosis in '94 was about 73%. 6 years later, in 2000, it was still around 70%. And the most common misdiagnosis was due to unipolar depression, that was the most common misdiagnosis. And the biggest concern, as I've indicated here, treating a person that's bipolar as if they are unipolar depressant, is you can actually switch them into mania, and you can worsen the symptoms, particularly the manic symptoms, and get them into either mania or cycling acceleration. So that's the big thing. We've talked about this yesterday somewhat, but there's actually been studies that have looked at the misdiagnosis. So what have we done to sort of help with the recognition of bipolar? One, surprisingly, we've increased over the years, and this has been recommended by a number of organizations, is to educate. We should not only list physicians, we should say prescribers, because we do get, nurse practitioners and physician's assistants, and they really, think about it. You guys get criticized for not having a lot of medical background, but on the other hand, we have a lot of people prescribing psychopharmacological agents that don't have a lot of psychopharmacology or, mental illness background. So one of the things was basically, for example, educating physicians that many times the way it shows up in the clinics is the person shows up during the depressed phase. Another thing is to start routinely asking patients if they have a history of some of these symptoms of bipolar disorder, and if they have a potential history in their family of that. Many times family members can give some good insight and involve them in clinical evaluations. Educate the families, the patients and their families, caregivers, about the disease, how we're treating it, what we have to look for, and that sort of thing. But a big thing is just being aware and screening for bipolar disorder, especially if the patient presents in a depressed state. This slide is a little complex. I want to point, and it's not in red, but I want to point out something to you. I really want to focus on this top section here. And the main thing I want you to be aware of here is that we talk about dose response curves of a drug, and a lot of people think it's a dose response curve for all of the effects. And so this is an example of that there's dose response curves for different effects of a drug. Like we talked about a lot of the anticonvulsants. So we find that there's a pretty good dose response curve from a standpoint of time, is that people that are having seizures and we're really treating them for the seizures, is we can get a pretty quick response in a very short time period. But then when we start looking at other treatments, is, for example, we've talked about mania and depression. The time onset is
much greater, and the dose response curve is flatter. So one of the things that we have to do is that when we are, for example, if we're treating somebody for seizures and the drug wasn't working, then we would be more likely to increase the dose or change drugs fairly quickly. That we can't really do, and we see that a lot because, for example, we're treating somebody with mania. Some of the effects may not take place for a few days. So those first couple of days, if they're not responding, there's a tendency to start increasing the dose or adding drugs on or whatever. So what you have to realize, and same thing for depression, which may take a longer time. So one of the things we've seen in people that are not aware of these type of issues is trying to educate them from a standpoint of letting them know that it's going to take a longer time to get these. Even when we start getting a response for the depression, it's still going to take a while before it basically will max out. So that's the only thing I wanted you guys to be aware of this slide is that sometimes clinicians think of drugs having one dose response. The drugs have a dose response that there can be multiple dose responses. So we know, for example, that there's a therapeutic dose response and a toxic dose response. And what we would like to do is have those two dose response curves separated as much as possible. Now, a couple of other things is what do we do? We've talked about substance abuse, and what we find is that a lot of our patients are going to have substance abuse problems. So what we have seen is if the person, and this is not uncommon that with them having a substance abuse problem, if they have this mixed or rapid cycling that occurs, and we have an alcoholic. One of the things we see is that their recovery is going to be both their recovery with regard to the bipolar or the treatment of bipolar and their recovery possibly from alcoholism is going to be slower. And we find out that there's usually a poor prognosis. We typically see with substance abuse that the effective illness tends to have a more severe course. We see the onset of mood disorders usually occur earlier. A lot of times we have some panic disorders that are mixed in with that, and we can also have PTSD in there. Makes it very difficult, very complex patient to treat. There have been some studies that have looked at different drugs and how they work with regard to substance abuse. So there have been some randomized controlled trials, one looking at lithium, one looking at carbamazepine, one at valproate, the other one neuroleptics. And so just to quickly give you these, so what they did with lithium is a pretty small trial. They had 25 adolescent patients. The patients were diagnosed as being bipolar or major depression, and they were using alcohol or marijuana. So they were split into two groups, either lithium or placebo, followed for 6 weeks. And this one, again, this is a very limited study. What they did was they monitored urine drug tests. Okay, so small study, 25 patients, and simply looking at the number of positive urine drug tests was their main outcome. Doesn't give us a whole lot about how these individuals, what their mood and affect and everything was, but what they saw that when you took these people and put them on lithium, that there were fewer positive urine drug tests, which suggested that it was decreasing substance abuse. And Joy, you bring a good point here is that a lot of times people want that instant diagnosis, and with substance abuse, and a lot of times trying to figure out what is contributing to what is very, 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 very difficult, and can't be usually done that quickly. So that basically, again, somebody comes in or a caregiver brings their child in and they want an immediate response, and you just can't do it. You have to, take the steps, and you have to explain to them. Another study looked at carbamazepine in patients that were dependent on cocaine. Relatively small study, again, 57 patients. What they saw was that
there was less cocaine use in the patients with carbamazepine. There was another, Brady also included, they did cocaine dependent patients that didn't have mood disorders. This had 82 patients. This is the same study. And they didn't see any difference in cocaine use with carbamazepine. So their conclusion is that the carbamazepine helped the mood disorder, which decreased the substance abuse. Valproate, they took bipolar patients that were alcohol dependent and on lithium. Again, note the number of patients. This one was 59 patients. Followed them for 24 weeks. And basically self-report, the valproate treated group, they self-reported fewer heavy drinking days and fewer drinks per heavy drinking days. The patients getting the higher valproate levels had decreased alcohol use, but there was really no significant changes in manic or depressive symptoms. So the valproate, even though it didn't change the mania or the depression, still seemed to help reduce substance abuse. And then what they saw what also has been recognized is bipolar patients that have substance abuse typically will get higher doses of antipsychotics, and 2/3 of bipolar patients they have on chronic neuroleptics. Now, using neuroleptics here is basically they're using the term as an antipsychotic, not for just conventional agents. All right. It's a good place to take a break. Let's, this is our last, this will be our last big break of the day. We'll take a shorter break, a little in about an hour, but let's come back at 10 after the hour, and we'll then talk about some of the severe dermatological reactions and then finish up with drug-drug interactions or drug adverse events, okay? All right, so come back at 10 after the hour. Over that, I forgot about that. So we will, there we go. All right, so if we go through this quiz very quickly, question number 1, which of the following is useful because of its ability to reduce weight gain? And the correct answer here is C, as in Charlie, topiramate. Question number 2, verapamil's mechanism of action involves, and that is calcium blockade. Answer is A. And then 3, Symbyax is a combination product that includes an atypical plus an SSRI. Remember, it has olanzapine plus fluoxetine. So again, just to go over the answers, question 1, correct answer is C as in Charlie. Question 2, the correct answer is A. And 3, the correct answer is B as in boy. Okay? All right. Now, we have talked about with these anticonvulsant reactions, and this sort of moves us into, it's going to move us a little bit into the drug interactions things also. So the severe dermatological reactions are basically when we talk about the severe reactions, we're really looking at Stevens-Johnson syndrome and toxic epidermal necrolysis. There is another drug, another condition known erythema multiforme. That is actually broken up into erythema multiforme minor and major. And there is also, what makes this confusing somewhat is that in the past there was the way it was defined, there was some confusion that some people that erythema multiforme major was actually some cases of SJS in 10, of SJS. So we're going to focus on just Stevens-Johnson syndrome, which is sometimes, Stevens-Johnson syndrome and toxic epidermal necrolysis. Typically, people start off, the big difference between SJS and 10 is body surface area and how much involvement is there. So typically, I think I mentioned this earlier, the way we define it now, if it's 10% of the total body surface area or less, that is referred to as Stevens-Johnson syndrome. If it is 30%, if it's over 30%, it is considered toxic epidermal necrolysis. And if it's between 10 to 30%, then a lot of times it'll be classified as Stevens-Johnson class /10. Now, when this starts developing, we see that, and one of the reasons that people described it as a continuum is that when it starts developing, for example, the person may start breaking out, and so they may start breaking out and only 10% of their body area is going to be affected, but as it progresses, more and more parts of the body become affected. So it may start out at SJS and it may emerge to 10. And on some medical records, sometimes they will just basically refer to it SJS, even though when you look at the body surface area, it may actually be 10. So this can progress rapidly. There's been different studies or case reports and stuff that if people have been exposed to the agent before, it's possible in many cases that a person has been exposed to the agent for a while and have no problem, or previously, and then may develop a reaction later. And also what we see is sometimes that when people are exposed previously, it may progress quicker. So there's actually been studies where, or case reports, I should say, where people have been exposed to whatever's causing it, and almost all cases of 10 are drug induced. But the first Stevens-Johnson case that I ever dealt with was there was a Black lady in Philadelphia who went into the hospital and was experiencing SJS, got a derm consult. The dermatologist said, yes, this is Stevens-Johnson syndrome. That is appears to be because a reaction to ampicillin, which is a penicillin derivative. And the resident stopped the ampicillin, but then started her on amoxicillin. That was like throwing gas onto the fire. Basically, she went to full-blown 10 and ended up dying. One of the questions was with her is when she got the ampicillin to begin with, there was no history of her ever having ampicillin in her background. Of course, there was a concern that, she may have received it as a child or something, but the evidence suggested she had not been exposed. And what they discovered was probably her exposure to the ampicillin and initially developing it was probably through antibiotics in food. But this clinical symptom, or these, when Stevens-Johnson and toxic epidermal necrolysis start developing, what you start seeing is blistering on the skin. This will progress. It a lot of times will involve mucous membranes. Very commonly, individuals will develop their lips and the inside of their mouths will develop blisters and cracks open and bleeding. And a lot of times there'll be crust around their lips. The eyes in particular are very sensitive. Ultimately, their eyes may crust over or may become very, we refer to it as injected, so that they look like they're really, really red and itchy. That can progress to where that literally their corneas will melt. So these, and this can go down mucous membranes. We see the most severe cases, excuse me. The most severe cases that I've seen, it's gone down into to the lungs and into the bronchioles. We've also seen it go into the urogenital tract. the lower GI tract, and well, the GI tract in general. So we get a lot of mucous membrane in the urogenital area, the rectal area, the throat. Many times what will happen is if they recover from the initial onslaught, a lot of times what will happen will be that they get a lot of scarring, and those scars can create a lot of issues. For example, a lot of young young girls that have developed this are probably not going to be able to have children because of the scarring in the urogenital tract. People can have lung problems, difficulty breathing because of the scarring. The eyes are particularly susceptible. We see blindness, we see photosensitivity. One thing that becomes pretty painful and irritating is the individuals, their eyelashes will actually start growing to the inside. So if you've ever got an eyelash in your eye, you know, that can be very uncomfortable and even painful. And so these individuals, their eyes will be very photosensitive. And every time they blink their eyes, they basically have these eyelashes that are rubbing the inside of the eye. So it's a very, very serious condition. And people that die, usually it's almost like, you know, secondary to like the burn, like to a burn. So erythema multiforme, this slide here, it shows, we call this a bullseye or a target lesion. Looks like a bullseye. A lot of times erythema multiforme is caused by infectious agents. It can be by drugs, but almost always it's by an infectious agent. For example, there is Mycoplasma pneumoniae, very common respiratory infection that children get and adults get, can cause this. This is SJS/TEN. What you have here is you have major loss of skin. This is one of the things we see with SJS/TEN a lot of times is that the rash tends to be more truncal. It tends to develop on the main central part of the body, the back, the chest, the abdomen. There is a thing called the Nikolsky sign, which is if you take your fingers or your hands and you push against the skin, literally the skin pushes up, a little separates out. And the definitive diagnosis for SJS/TEN is they will do a biopsy and look at the dermal biopsy. So they'll do a full skin biopsy and determine where it's been separated. But again, here's an individual on this picture here that is, you can see the entire chest has almost been exfoliated. You can see some blisters down here that have been formed, and those will eventually coalesce and that skin will pull off. So that is sort of where we're finishing up. There, if you, Rebecca, I'm going to send you guys an article that's just I think it's a continuing education article about skin disease, but SJS/TEN. But it is a very, very serious. Fortunately, it's very rare, but it's important that we know and warn people when this can occur. So if they start seeing these drugs that can cause rashes, or when the rashes develop, we want to stop those because it's a possibility of developing. We do know there's been some studies that basically have identified that the sooner we stop the drug, which fits with a lot of drugs, the better the prognosis. We've seen a lot of drugs. I mean, you know, I've done most of the work that I've done as an expert for the plaintiffs. Ibuprofen and naproxen and Tylenol, those drugs can cause it. And so people would take it and the disease would start emerging. And of course, they would think it was secondary to a fever or something. So they'd take more Tylenol or more ibuprofen. And so they would we had, you know, even physicians years ago, the warning that warned for this actually came out in 2005. But over-the-counter medications containing ibuprofen and Tylenol and naproxen can cause that. Again, it's fortunate that it's rare, but on the other hand, it's important to recognize it early. So very, very serious. All right. Last part of the day, we want to talk about drug interactions. Throughout your training that you've had in this curriculum, we have, in essence, talked about drug interactions. As you've gone through, as you go through the advanced training, we talked about drug interactions today with the bipolar. So when we look at drug interactions, we're looking at, we're going to talk really about adverse drug events and drug interactions. The first thing is the term drug interactions. Most people see that, basically they think of that as a bad thing. But drug interactions can be beneficial, okay? In fact, we take advantage of drug interactions when we do combination therapy. We are betting on that these two drugs that two or more of these drugs are going to interact, but we're going to use that interaction to really try to do two things. One, we can use lower dosages of a drug, which means typically less chance of a side effect. And secondly, by using combination therapy, we can many times hit a disease state through multiple pathways. So that's good. So we're hoping to improve efficacy, and we are also hoping to minimize side effects. Okay, now again, as I've indicated, this is combination therapy. This is not polypharmacy. Polypharmacy is bad. Polypharmacy literally means too many drugs. So combination therapy is a very rational combination where you are taking advantage of either a pharmacodynamic interaction, so one that's happening in the tissues, or you're taking advantage of a pharmacokinetic interaction. Okay. Now, some of these drug interactions can actually boost pharmacokinetics or help us with pharmacokinetics. My daughter, the one that passed away, when she had been on a lot of narcotics and we put her on Suboxone, we discovered she was basically, her body was metabolizing the Suboxone really too fast. So what we did, can be an advantage and a disadvantage of having a dad as a pharmacologist. Talking with the doctor and I came up with, well, let's give her zithromycin. So that's an antibiotic which interferes with the metabolism. So we were able to use azithromycin to slow her metabolism down so the Suboxone would work. So there's ways that we can, and we talked about today, where carbamazepine can induce drugs or induce enzymes and therefore can increase metabolism, which can sometimes be good and sometimes be bad. But we can use it for beneficial. We can inhibit a metabolism, or we can speed up metabolism to be for a therapeutic advantage. And we also can use those drug interactions with combination therapy to reduce toxicity. So by not only sometimes we can use drugs to offset or prevent a toxicity, but also by using combination therapy, we can often result in using lower dosages. What most people think of when they see drug interaction, we hear the term drug interactions, comes down right here, is most people think it's harmful, okay? Most people think of that increased drug interactions is equated with increased toxicity. And not only with increased toxicity, but also a decreased therapeutic effect. For example, with carbamazepine, we talked about, let's say, the oral contraceptives. One of the things is going to be is carbamazepine induces metabolism. And what that can do is it metabolizes the drug too quickly. Sometimes a drug interaction can be, it prevents the drug from being absorbed. People taking antacids, a lot of time the antacid may tie up a drug, or some of these cholesterol drugs that we try to increase the excretion of fat. Sometimes they're referred to as fat blockers. The drug, if it's lipophilic, can be caught up in those fat blockers and create a problem. So drug interactions can be both beneficial and they can be harmful. Recognizing those drug interactions would allow us to either take advantage of them or avoid them. I don't know if you guys can hear or not, but Big Al is over here snoring, and he sounds like a big alligator, big bull alligator here. So I guess he's bored with my lecture here. he must not care for drug interactions. When we talk about drug-drug interactions, one of the things is it's very difficult to determine the true incidence. One of the reasons is that we find, first of all, in the United States, our adverse event reporting system is what we refer to as a passive reporting system, the MedWatch program. Clinicians, healthcare workers are not required to report adverse events and drug interactions. We encourage everybody to. We've talked about how you guys would do it, but we only see probably at best, at the very best, we may only see, some people would say that probably drug adverse events, maximum of 10% of the real, of what's actually out there is actually reported. And that includes even like Stevens-Johnson syndrome and toxic epidermal necrolysis. A burn surgeon that treats these all the time at an academic center, which is people get referred to that center, has said that he as a burn surgeon just doesn't have the time to do it. He realizes it should be done, but he just doesn't. Says he just doesn't have the time. So we don't really know the true incidence. And when we talk about drug-drug interactions, we may not know those. Some of that information will come out when the drug companies are, basically developing their drugs, and they will look for certain drug interactions. Some of it will come out because somebody will write a case report up, or someone will do a case series where that they're starting to see something like that. So the data is sort of incomplete, just the way that reports it and required to report it. Literature, most of those studies in the literature are case reports or a series of case reports. Another thing that comes into play is that sometimes a drug-drug interaction may actually be just simply reported as an adverse drug event. So, for example, if someone took two drugs that, there was a drug-drug interaction, the last drug they took, which the interaction may have popped out with, may have been the one that they report, but they may not be aware or may not report the other drug. So if it's classified as an adverse drug interaction, we may not know specifically if there was another drug. Now, when we're evaluating, sometimes when you're evaluating adverse events, you may see a common denominator where that all of the people having the adverse events were also taking another drug. And so that sometimes may emerge. So many times drug companies should be doing that. Sometimes the FDA should do that. But again, sometimes this is very easy to miss it. So sometimes an adverse event may show up, and we may find out later on that adverse event actually occurs because the drug-drug interaction causes it. A big issue that we're dealing with here is over-the-counter drugs and supplements. These are very difficult to track. Over-the-counter drugs, these have to go through approval. Many times these over-the-counter drugs have gone through the same approval process that have been, at first were prescription drugs and then have been approved to go over the counter, usually at a lower dosage. But the problem, and so drug companies are monitoring that, but the problem is by definition, an over-the-counter drug does not require oversight by a physician or oversight by a prescriber. So the patient goes and chooses the over-the-counter drug. The patient is getting information, and a patient, if they have an adverse event, they're probably not going to basically report it. What happens there are they basically result in the patient usually just stops taking the drug. So when we're looking, here's the other thing that's interesting. When people are looking at adverse events, a lot of times they like to go, well, this is, they normalize it by the number of tablets or capsules that may be, or units that are sold. And that's normalization. So they may say, well, we only saw one case of Stevens-Johnson syndrome with over 3 million doses of this drug sold. Well, the problem with that is that's assuming that everybody, so they have the sales data, but that's assuming that if someone bought a bottle of 100 tablets, then the issue is that we're assuming that they took all 100 tablets. I think most of us would be able to go into our cabinets and find bottles of potentially ibuprofen or Pepto-Bismol or whatever that was never taken. Or somebody may have not taken it, bought it, but didn't take it, looks, the expiration date is gone, so they throw it away. So that normalization, you have to remember there's a limitation there. If I take a drug and I don't like the way it tastes or it makes me feel bad, I'm just not going to take it anymore. And so that's the problem with over the counter. Even though the FDA requires drug manufacturers that sell over the counters to monitor this. But again, most of the public is not going, if they take something and makes, the biggest thing we see with the public turning in to the MedWatch or something is they will occasionally send in a note that they want their money back because the drug doesn't work. So that is classified as it's not a serious drug interaction, it's classified as a lack of efficacy, which the drug may not have worked because the patient may not have used it correctly or whatever. So we do see a patient turn that, but most people taking the drug would not know specifically how to contact or who to contact, even though they could turn in, if I took a drug and got a rash and I was Joe Public, I could actually turn it in on the, I could actually send it to the FDA through the MedWatch form. I could send it to the company saying, I took your drug, and that's what we see sometimes. I took your drug, made me sick, I want my money back. That's what we may see. Or if they go back to the pharmacy to get their money back, then the pharmacy may not turn it in. They're not, CVS, Rite Aid, Target, all these different pharmacies are not required to turn those in. And many times they're going to be too busy. If you carried it back to the doctor and said, maybe the doctor told you to, well, go take some aspirin, and you went and bought some aspirin, you're not going to go back to your doctor and say, well, the aspirin doesn't work, I want my money back. Supplements are even harder. The FDA has no, basically supplement companies. So the FDA doesn't do any safety or efficacy, require any safety or efficacy treatment of the, or safety or efficacy data from these supplement companies. And so the supplement companies, I've dealt with some of these in the past, and they will keep a adverse drug event, or they monitor that, and most of them it's a file folder in the top desk drawer. But many times people are not going to contact them and suggest that. So supplements are really hard. Now, when the FDA starts seeing somebody having problems, they may go in and find out. Sometimes they find out that there's contaminants or something like that, and it may occur. So let's look at, we mentioned a couple of these earlier today. So we have pharmacodynamic interactions. This is where the pharmacological effect is altered. Typically, we describe this as additive, synergistic, or potentiated. If you remember back when we talked in pharmacology many moons ago, additive would be equivalent to, I use, let's say, heart rate. So drug A raises my heart rate by 10 beats per minute. Drug B raises my heart rate by 10 beats per minute. So the combination of the two, my heart rate goes up 20 beats per minute. So it's simple additive effect. Synergistic is, it's more than additive. So drug A raises my heart rate by 10 beats per minute. Drug B raises my heart rate by 10 beats per minute. But when I combine them, then my heart rate goes up 30 beats per minute. So it's more than the additive effect. And then potentiation is where that one drug doesn't affect it, but in the presence of the other,
is it has a greater effect. So drug A has no effect on my heart rate. Drug B has an effect on my heart rate by, in the presence of drug B, then my heart rate may go up 10 or 20 beats per minute. So pharmacodynamic generally is going to be involving, the receptors or the actual pharmacology at the tissues where the mechanism of action is going to be affected, okay? You could almost argue, too, another pharmacodynamic interaction could be antagonistic, which means that one drug blocks the effect of another drug. So that would be like a beta blocker. And we do have, speaking of beta blockers, for example, isoproterenol, one of the things that happens with it is sometimes it's metabolized to a metabolite. So isoproterenol is a beta agonist, so it stimulates beta receptors. We used to use it to stimulate the heart, or we used to use it for asthmatics. But we found that with asthmatics, a lot of times when they were using it chronically, they would get a buildup of one of the metabolites, which actually was a beta antagonist. So the metabolite would actually block the effects of the parent compound. And also with pharmacodynamic interactions, it could involve metabolites. So we do have a lot of drugs. For example, a lot of the SSRIs have active metabolites which can contribute to and even increase the pharmacology of the drugs. The pharmacokinetic is where that it's altering either the absorption, the distribution, metabolism, or the excretion of the drug. So typically, that an pharmacokinetic interaction will alter the amount of drug that gets to the receptor or to the pharmacological site. So as we said earlier, one of the things that can occur, like somebody takes antacids, if they're taking an antacid and that antacid binds up your drug that you're prescribing, say for example, one of your antidepressants, then it binds it up and therefore it doesn't get absorbed. So then it will be excreted and never gets to the site. We've talked numerous times about metabolism, where that a drug can either inhibit, induce metabolism that can create problems. And one thing to be aware of is that this metabolism and also excretion, we think about the liver and the kidneys, but we can find some transporters can be involved too. Sometimes these drugs can alter the transport of these drugs, so that can affect the absorption from the GI tract into the bloodstream, or sometimes it may affect like a drug being transported into, for example, the brain. So the absorption, one of the big things we look at is food. This is going to always be an issue. Now, sometimes we want food in the stomach because that will help protect the stomach so that the drug doesn't, is sort of buffered by the food. But certain foods may actually increase GI motility. Some hot, spicy foods sometimes increase GI motility. Some foods may bind up the drug. Sometimes we don't want people to take medications with food. Sometimes we tell you to avoid milk products because some of these sometimes medications can be tied up with some of the milk products. And that usually is through a process called chelation. Antacids do it, and dairy products do it, and iron can do it too. So what happens with chelation is think of it sort of like a cage that when the drug is in solution, so this is actually primarily a chemistry reaction. So what happens here is when the drug is in the stomach lumen or in the digestive mix there, is these drugs just trap it and will not allow it to be absorbed. Sometimes they trap it so it sort of like encapsulates it so it can't be absorbed. Sometimes it traps it simply, it's too big for it to be absorbed. So what happens with that is basically the drug doesn't get absorbed, it just gets excreted on through the feces. Another thing we have to take into account is altered GI motility. I touched on that just a little bit, but let's look at some options of things where GI motility may be altered. So here's what we first of all think about. When you take a drug, it goes down through the esophagus, it gets into the GI tract, it gets into the stomach, and most drugs are going to be absorbed in the small intestine, okay, the duodenum. So one of the things is if GI motility is altered, let's say GI motility is slowed down. Maybe somebody has some sort of disease that's got GI motility slowed down. So we give a drug, and what happens is it stays in the stomach for a longer period of time simply because things are not being moved through the GI tract. So one of the things that can happen is that if some of these drugs, if they stay in the stomach and they're very irritating, they can create indigestion, they can create damage actually to the stomach. We may actually see the ulcerations occur or bleeding occurs. So that's where an irritating drug doesn't get moved through the stomach quick enough. Sometimes irritating drugs, what we do is we put them in, like we enterically coat them. One of the things that happens there is if the GI motility is increased, we may move it through the stomach too quick so that the enteric coating doesn't have time to dissolve. Things that we have to think about sometimes, gastroparesis. People with gastroparesis, their GI motility may vary. We have people that will have gastroparesis that will move stuff through their stomach very quickly. That can affect absorption. And then they'll have periods where the gastroparesis maybe resolves. And so during the course of taking prescriptions, one of the things that you see is basically where that you have altered absorption. A big thing that that's emerging or has emerged is people with gastric bypass. So when you do gastric bypass, whether you put a balloon in there, whether you go in and surgically staple the stomach, one of the things that they do is you're changing the volume in the stomach and the time it takes to go through the stomach. So that can have, one of the things that's coming up is, for example, people that drink alcohol that have had gastric bypass, is it goes through the stomach quicker, so they may actually absorb the alcohol quicker. So anything, and to keep in mind that sometimes some drugs, you guys will prescribe a number of drugs that have anticholinergic actions. Anticholinergic actions are going to slow GI motility down. So this can be a big issue that comes into play with regard to these drugs. So this should be a big review for you. You should have had this ad nauseum, but when it comes to drug-drug interactions, always keep in mind that the liver is going to be a big situation. Drugs that are going to be metabolized. Remember, we've talked about one drug that doesn't get metabolized, which is lithium. So these drug-drug interactions really, metabolism interactions usually don't occur. But so one of the things that we have is, we talked about today, substrate inhibitors, or inducers, I'm sorry. So things like carbamazepine. So what those drugs, what happens there is that you increase the number of enzymes or the amount of enzyme, which means the body can metabolize it quicker. So a substrate inducer may result in the drug being metabolized quicker, and therefore you may have a subtherapeutic effect. Now, a big difference is, what if you have a prodrug? If a prodrug, what you're expecting it is the drug is given and you're expecting on the liver to metabolize it so that it becomes active. So if you have a substrate inducer, you may actually get a supratherapeutic effect because the inducer may be breaking down the parent drug compound and creating the active metabolite or the active component quicker. Let's jump up here to substrate inhibitor, which these are, cimetidine is a good example. We find that a lot of drugs can inhibit the substrate. What happens there, the drug is not being metabolized, and so it accumulates, and we usually get side effects or toxicity. What happens with a prodrug? Prodrug, if it's not being metabolized and it's backing up, you may have a subtherapeutic response. So one of the things we're going to take a break in just a minute, I'm going to want you to think about is, what happens with a prodrug, what happens with both with an inhibitor and inducer. The third thing is competing substrates. Sometimes two drugs are going through the same enzyme pathway, and it's just like going down a one-way street, is that it's designed to go, one drug or one car. And so what you may see with a substrate inhibitor or with two drugs going through the same substrate is basically the enzyme is going to be trying to metabolize both, so you may get a reduction in that. So one of the things that we look at when we see this, depending on what's occurring, we can get an increased substrate concentration. So the drug accumulates and we get side effects or toxicity. We can get a change in toxicity or efficacy depending on what has to be converted, and we can get a decreased efficacy. So this is going to be some of the things that we have to sort out with regard to these particular things. All right, so this is a good place for you guys to think about it. Let's come back on the hour. That'll give you guys about 10 minutes. This will be our last break for the day. We will come back and we're going to finish up on drug interactions, and then we'll let you guys have your quiz, and we'll be done. So see you guys on the hour to get to the next section.
Doctor, I'm gonna run the attendance right now too.
Sure, no problem, Aiden. We're on the downhill side of this one. Another course is going to be under your belts. And so Aiden has done the poll here. And so we're going to move to the next slide, which deals with drug transport. So this is something that we have not gotten, we're getting more information about, but it's still behind where we were with regard to like other things. We do know that there's a lot of transport proteins. And so now there is a lot of things to catch up with regard to, with the drug metabolism. So the transport proteins, basically most of these are they're effluxing or carrying things out of the cell. So for example, we have some transport proteins which basically may extrude the drug from the GI back into the lumen. So that's one thing that can happen. So these transport proteins basically will many times limit drug absorption. And some of the ones that have been identified, one class in particular is the P-glycoproteins. We've had a lot more information on those. In fact, we covered a little bit of those when I covered general pharmacology. And then we have MRP1 and MRP2s, and then the OAT3. So those are things that occur. And then we can also have induction and inhibition of these drug transport proteins. So we can have very similar things that happen with regard to the liver enzymes. So let's take a look at a couple of these. One of them, we also have some uptake proteins. So these are the things that pull it in. One is called the OAT protein, OAT protein. This one is actually located on the enterocytes of the GI tract. And what these do is these actually promote absorption. So from a standpoint of, this is an important one because this one comes into play because what it does is it helps transport drug across the lumen. And so one of the things that can happen sometimes is that the fruit juice, in particular grapefruit juice, some of the interactions that we have may be due to an interaction with these uptake proteins. I see what you guys are doing with regard to when we take these breaks. And so I just consider that it's multitasking, so that I'm sure when y'all are like cooking, feeding your dogs and everything, is you're carrying your phone around so you can be studying this. And so from a standpoint of Eddie, I have some yard work that needs to be done too.
So I'm thinking about, see if I could develop this thing where that maybe put it on a lawnmower. So I have my laptop on my lawnmower so I can just start, lecturing with you guys from that. So when I feed my dog, you guys all hear it because Big Al's munching down now. So, and we all know the issue that sometimes if we get caught and don't get back up, we can always default with the I had technical difficulties or connection issues. So that would be very interesting. Is we're gonna one day just tell everybody you got to walk around with a Self Pro so we can play those to see what we can do. From there. One of the first classes that I taught here, one of the students always took on the or listened to the course in his living room, and his kids were always coming up, and he would forget when his mic was not muted. The other thing was, I thought the other students was gonna literally go over the phone and kill him because this is when I was flying to Baton Rouge and giving these lectures. But this guy was notorious for both when he ate lunch and when he snacked was crunchy foods. Literally, I almost had a revolt when, and he would mute a lot of stuff, or he'd have it turned down so he couldn't hear the other people. So he would be sitting there eating crunchy cereal, and we could hear every crunch, and he was a slow eater. So the only thing worse was when he ate celery and carrots for a snack. So when we're looking at getting back to the thing, so I can get you guys done and return you to your lives like the Twilight Zone movie used to say. When we look at drug interactions, typically what we see is inhibition can occur pretty quickly. Pretty much what you can have is this can be, literally within minutes. So inhibitory responses are fairly quickly and easy to pick up. On the other hand, enzyme induction takes longer. Sometimes it may take weeks, but usually several days to weeks for those enzymes to actually be induced, because what you're doing there is you're actually having to generate new enzymes. So that is going to necessarily take a little bit longer just to generate new enzyme or to formulate or synthesize new enzyme. Whereas inhibition, basically, you're just pretty much becoming either inhibiting an enzyme from working, which can occur simply by a drug binding to that. So that's an issue that can occur there. So if you have an issue, the thing to remember with this is basically inhibition can occur, within a dose or two, whereas induction is not going to usually occur for at least a few days, usually several days. Well, Joy, the one thing I would tell you about that, it's not as bad as when I was giving a lecture to my students, and we have a couple of students that had service dogs. And in the middle of one of my lectures, the dog was sitting on the front row, and he just made the biggest yawn. Like, I am really bored with what you're having to say. So I took that so personal, Come on, slides. Okay. So because that the inhibitors occur, that inhibition occurs so quickly, basically it's pretty easy to detect inhibitors. Those are the ones that the drug companies can find pretty quick. Those are the ones that we will usually recognize. Once a drug has been marketed, we may see, an inhibitor or information about an inhibitor pops up because as the drug gets out to the real world, we may see people taking drugs that we may not have recognized or thought about that they would be taking during clinical trials. But one of the problems with these inhibitors and inducers is sometimes these drugs, every now and then we'll have drugs that, not every now and then, frequently we have drugs that may be metabolized through multiple pathways. And when they're metabolized through multiple pathways, this makes it much more difficult. A lot of times you may have a major pathway and a minor pathway, but it can still confuse things, and those are difficult to sort out. When the statins were coming out, and one of the things, Baycol was a drug that was pulled
One of the things that they were trying to say is that our drug is metabolized through a major and a minor pathway. And they were trying to tell doctors that basically if the major pathway is inhibited by a drug, then the drug will go through the minor pathway. Sort of like if the one-way street is blocked, we can go take the detour. Well, in one sense, that was true. The fact is that if the major pathway was blocked, the minor pathway would still work. What was not true was the doctors were sort of thinking that the drug would all go through that minor pathway. The difference here is that it takes longer. That minor pathway may not be able to accommodate all of the drugs, so you can still have a drug interaction. But if there are multiple pathways involved, this can sometimes create problems to sort of extrapolate data. We may not get as much inhibition. Sometimes we may get just as much. One of the way that we've started doing, and drug companies do this now, they're required by the FDA that when they put a drug forward, that they have to determine the metabolism. So they look at the metabolism pathways. And one of the things that they do is they can look at cytochrome P450 drug interactions or drug pathways using what we refer to as a probe. So they'll find a substance that goes primarily through one pathway, and then they will add an inhibitor inducer to see how it affects it, and then you can see if the drug does it. So what you can do is you can basically, you know what the probe is, the chemical that you're going to use, you give it, and then you basically measure the probe and its metabolites. And because we know we've got those pathways identified for that particular thing, it can give us a good idea of what's happening. Then we can look at the ratio of the metabolites to the parent compounds. So that's one of the things. Or we also use these type of probes to determine if someone has a polymorphism of a particular pathway. So some of the probes, and I'm not asking you to memorize these or for the test. For example, caffeine goes through 1A2. Warfarin and tolbutamide, two drugs there, will go through 2C9. Omeprazole, very common, acid reducer, will go through 2C119. Notice the two drugs, the two that we see a lot of with regard to 2D6 and 3A4. Back here is we can use, a lot of times they use dextromethorphan can be used, but many times they will use dabriciquin or Spartine to look for the 2D6, and with the 3A4, erythromycin or midazolam can be used, typically erythromycin. So there will be some more probes that will be coming out, and we'll also see more probes emerging with regard to the some of these transporters. So that's how we're looking at those. Now, the last part of my lecture that I'm going to finish up with is hit a few serious drug interactions that pop up all the time. And one of them is serotonin syndrome. With the drugs that you guys prescribe, this is one that's important. Now, this is important because it is potentially life-threatening. And it is due to an interaction of two or more drugs that actually increase the serotonin, not only in the central nervous system, but they may also increase serotonin in the periphery. So it's important because of the potential life-threatening aspects of it, but it's also relatively rare, okay? But we see people, every time someone has a drug interaction that has a drug that may affect serotonin, they always yell serotonin syndrome. Typically, this is going to occur pretty quickly, within a few hours after the two drugs being given. And what is commonly seen, I said commonly seen, there are instances where that not all three of these things, we call it there's a triad that we see. There's really three major things that occur typically. One is neuromuscular excitation. What we typically see, this is due to the serotonin effects in the brain. We see clonus, we see hyperreflexia, we see myoclonus and rigidity that develops, okay? So that's the neuromuscular component. What is probably the most serious component is this one,
is excitation of the autonomic nervous system, and that can result in an elevation of hyperthermia, so elevation of temperature. So body temperature can really shoot up there, and that can be life-threatening. Heart rate can go really fast. We can get tachycardia, and we can see either an increase in blood pressure or a decrease in blood pressure. The increase in blood pressure can occur from a number of reasons. The decrease may occur because the heart's beating so fast that you can't keep the pressure up. Is there a window when the patient was aware of the onset? I think patient starts experiencing these, but so there is sort of like they can experience these occurring within hours. So what we try to do is, first of all, where I've seen this occur mainly is where a patient is getting medication from a couple of doctors or from an error, where a patient got a drug they weren't supposed to, typically. So, we see a lot of times they present probably with the agitation or confusion, and the autonomic stuff is things that we may see occur first in my experience in seeing these type of cases. So any drug that has the potential for increasing serotonin that's the first thing you want to look at medications to see that. Typically this can occur when someone has had a drug added, or it can occur when someone increases the dose of one drug. So you may be sitting there right on the verge with two drugs and you increase the dose, or maybe you have a drug interaction where the serotonin levels are increased there. The net effect is serotonin increase in levels. And again, a lot of times it's the hyperthermia and the tachycardia, the cardiovascular effects of the hyperthermia, which is the causes of of death. The drugs that are involved, SSRIs, you guys will prescribe those. Monoamine oxidase inhibitors. Typically, if someone is on a monoamine oxidase inhibitor and is taken off of it, we want 10 to 14 days, because these monoamine oxidase inhibitors typically bind irreversibly to monoamine oxidase. And so what we're looking for is it takes about 2 weeks to regenerate new monoamine oxidase. But so sometimes we find somebody's been on a monoamine oxidase inhibitor and they take them off that and put them on a serotonin drug. Stimulants can do it. A lot of the stimulants increase serotonin. Some herbs, so we have to be careful for supplements and so forth. Meperidine, this is a analgesic, a narcotic analgesic, which increases serotonin. Tramadol, very common pain medication, which a lot of people think it's the non-opiate opiate, and even dextromethorphan, available in a lot of cough medicines. So these are the drugs that are typically involved. We see a lot of times an SSRI or meperidine. The other ones, we see the tramadol, dextromethorphan when we've got real high levels. Sometimes we've seen people on SSRIs and take dextromethorphan and not have a problem, but then if they increase the dose of the SSRI or take a lot of dextromethorphan, that can occur. Remember, dextromethorphan is one of the drugs that's very commonly available over the counter in cough medicines, cough syrups. And remember that it's a very commonly abused drug. It's in things like Coricidin and stuff like that. So in a lot of the cough cold preparations, you got to be careful about that. Warn the patients about it. So what happens when this occurs? We start seeing it. Make sure you stop the drug. You don't want to keep feeding that serotonin. We see a lot of times chlorpromazine is given IV. We can use cyproheptadine, can be given orally, fluid lodum to try to maintain the cardiovascular system. But what I have seen recently is anytime somebody has a drug interaction and there's too serotonin, people immediately label it as serotonin syndrome. So I think there is a lot of potential serotonin syndromes that are brought up or, quote, put into medical records, which I don't think is necessarily a serotonin syndrome. Another thing we worry about is hypertensive crisis. Basically, with a hypertensive crisis, this is going to be more of a concern in patients with cardiovascular disease, people with hypertension, people that have had strokes or have risk factors for strokes. The elderly are particularly of concern. So what's going to happen here is basically the drug causes a big increase in blood pressure. The concern here is the sudden increase in blood pressure can rupture a blood vessel. If there's an aneurysm, that can rupture. Our biggest concern typically is a stroke, where the blood pressure goes up and you have a hemorrhagic stroke. So the very common things we see is we have the monoamine oxidase inhibitor, food interactions. You guys are aware of these. We've talked about them before, I think. When you get the antidepressant lecture, they'll talk about them. But red wines and flat beans and things like that, you want to avoid in someone with a monoamine oxidase inhibitor. Cheeses, right? Hard cheeses. Those are well known. Fava beans are there. Another interaction is sympathomimetics, drugs that release or stimulate the sympathetic nervous system. And if a person is on a monoamine oxidase inhibitor. So our concern here is many of the sympathomimetics are going to be the patients that go and try to take cough, cold, decongestants, cough syrups, things like that. So things like phenylephrine, Sudafed, those things over the counter are what we worry about in causing a hypertensive crisis. Psychostimulants can cause it. Most of the ADHD drugs can elevate blood pressure. And also things like cocaine, methamphetamine, sympathomimetic drugs that are abused can do that. Norepinephrine uptake inhibitors like tricyclic antidepressants. What happens is, in fact, cocaine and amphetamine and methamphetamine all act the same way, is by inhibiting the norepinephrine reuptake, basically the norepinephrine stays in the synapse longer, and in doing so, that can cause the blood pressure to go up. Hypertensive crisis, stop the drug. The other thing we're going to do is probably use drugs to try to lower their blood pressure. Another big issue that has really come out, probably the biggest thing was the antipsychotics, was when it was discovered that the new atypical drugs, although they were very good with regard to minimal side effects in many ways, we did find out that these drugs have a potential to prolong the QT interval. So what happens with the QT interval, I think I've showed it to you before, but with the QT interval, you want to make sure when somebody is going to be put on these drugs, an EKG is always good to look at, because some people may already have a prolonged QT interval, and if you put an antipsychotic drug on it, it could prolong it. So what happens with the QT prolongation is that is a sort of a precursor to the development of torsades. And torsades is a ventricular arrhythmia, well known with the antipsychotics. A few of the SSRIs it's been reported with, for example, citalopram. So if citalopram or some of the SSRIs can do it, then it's potential that at higher doses, some of the other ones can do it. The other thing is the tricyclic antidepressants. They're anticholinergic. And so by blocking the acetylcholine, that can result in tachycardia. So we can get that also. So arrhythmias and QT prolongation are things that we need to be aware of. And sometimes keep in mind this can be a drug-drug interaction, where that any drug that, for example, if you're on an antipsychotic, any drug that may elevate the antipsychotics level in the body, since this is usually a dose-dependent effect, if you elevate the level of the antipsychotic in the body, then basically that can result in the QT interval being prolonged and going to torsades. Seizures, another concern we have. In anybody that you've got that is that has a history of seizures, you always want to be careful with, because what can happen is, one thing is that basically there are certain drugs that may actually alter the neuronal properties and can result in the seizure threshold being lowered.
What that basically means is it's easier for them to seizure. So the things that we worry about with seizures, antipsychotics can do it, bupropion can do it, clomipramine has been shown to do it. The other thing is, I don't have them listed here, but some of the stimulants can do that. So we need to be careful with regard to patients, especially if they have a history of seizures, that certain drugs can cause this. The other thing is, even if you're using caution and a drug interaction occurs, which raises the blood level of one of these drugs, that can result in mirtazapine can do it too. Jeeb, good point there. So that's another issue that occurs. So other major drug interactions, we've touched on some of those. Let's see. So we talked about Stevens-Johnson syndrome. Think about Lamictal, a big one, the anticonvulsants, carbamazepine. Some individuals, for example, the Han Chinese maybe have that allele. So we are testing for that allele, and there may be some other alleles that may be identified with it. Non-steroidal anti-inflammatory drugs. I mentioned those, ibuprofen, Tylenol, naproxen. Those have been shown to increase SJS or cause SJS. One of the things that also is with selective serotonin reuptake inhibitors is you may be at an increased bleeding risk if they're taking non-steroidal anti-inflammatory drugs. NSAIDs, by blocking the prostaglandin, can cause the GI lining to become weak, and you can get some ulcers that occurred. GI bleeds with NSAIDs are always a concern. And when you have an SSRI present, one of the big things that you got to worry about is the SSRIs can increase bleeding risk. So when a person is on an NSAID, when a person is on any anticoagulant or corticosteroid and an SSRI, we want to be cognizant of potential for bleeds, okay? And then finally, one of the things that we always worry about is drugs that you may prescribe have the potential for producing SSRI, producing central nervous system depression, which can result in respiratory depression. So things like benzodiazepines, which you will prescribe, if the opiates, alcohol, this can be a deadly combination. So this can sometimes occur, cytochrome P450 is inhibited, which may increase your CNS depressant levels, which can then do that. That's why a lot of times we want people not to be drinking, taking alcohol when they're taking things like SSRIs or benzodiazepines and things like that. So any of the drugs that says use caution, those are all CNS depressants, and if we combine those, it is possible to get CNS depression. Now, how do we evaluate drug interactions? So if you suspect a drug interaction, here's what you need to think about. First of all, the time course. Is it related to an increase in dose? Is it related to the addition of a drug? Is it related to some change in the pathophysiology of the disease? Those are things that we come into play. We may also want to see is maybe we gave it, but it occurred a little bit later. One of the things we want to look is when does the peak levels of these drugs occur? Look into when the patient took the drug. Sometimes a patient may be taking the drug and then this develops, and you may find out that what's happened is the patient has changed the time when they took the drug, and that may account for it. A big issue is going to be, did we miss a slide there? Let's see. Yes, we did. Thank you for catching that, Eddie. My thing jumped right over it. So let me go back to this since I'm in the middle of this, and then I'll come back and pick up on the anticholinergic. One of the things is sometimes there's drug interactions, and the question really becomes, is it clinically significant? Anytime we have a drug interaction, we have to consider, all right, what are the consequences here? But one of the big things is going to be if there's a drug with a narrow therapeutic index, warfarin, lithium,
two drugs there that are big there. So a narrow therapeutic index is going to be more likely to have a very clinically significant drug interaction. If the toxicity that may occur is very severe, we've talked about a few of those, that's going to be coming into play with the clinical significance. Sometimes the issue may be it may make the patient uncomfortable, maybe get a little bit of nausea or something like that. It's not really severe. It could affect compliance, but it's not like we're going to be more concerned if it's something about it producing Stevens-Johnson syndrome or, increases seizures or something like that. So when we see a drug interaction, what do? One is typically we're going to discontinue the drug and then try to step back and take care of it. Sometimes we may have to do supportive therapy, but then it may be we simply change the dose of the drug, maybe go back to a lower dose. It may be that we have to change the drug. These are things that are concerns that we have. So let me go back to the anticholinergic toxicity, the one I skipped. So anticholinergic toxicity, this a lot of time is going to occur with tricyclics, antipsychotics, some of the antidepressants, because they do have some anticholinergic activity. So what happens here is we have excessive blockade of the cholinergic system. What we typically are going to see is, you guys probably know these by heart by now, is urinary retention, dry mouth, constipation, blurred vision, maybe some confusion, impaired memory. That is, many of these may just be bothersome. Some of them, the impaired memory, reduced ability to concentrate, could have a significant effect, but the other things usually will respond to dose reductions if we can get by there. But some patients, for example, dry mouth may be a big concern with it, has to do a lot of public speaking, or someone that has to, a salesperson, for example. The severe toxicity typically is if we get central nervous system, we may get delirium, but typically one of the biggest concerns is going to be the tachycardia, or maybe even a paralytic ileus, where the GI tract just sort of shuts down. Our elderly are at the greatest risk, and so we really want to be careful about that. And we want to make sure, a lot of drugs have secondary anticholinergic properties, and that is why we want to be careful, because sometimes people forget about those. You think SSRI and you think it's pretty safe, and it doesn't have that. This slide here that completes what I have to say. I'm going to send you guys an article on SJS. So for that, Aidan can post it. Now, Aidan is going to post the quiz, and he will have the answers, so he can post those up. So you guys will see the answers to that. I won't see you guys for a few weeks, so I hope you guys enjoy the next couple of weeks. I hope you have a great week. And now y'all can go out and really do all those things y'all had to do in 10 minutes, but you should have nothing to do since you got it all accomplished in those breaks I gave you. So you guys have a great week. As always, it's great interacting with you guys. And Aidan, I'll turn it over to you to have the quiz, and I will shoot you the exam, try to get it to you by tomorrow.
Thank you, Doctor. I'll keep it going for 10 minutes.